Today's webinar is titled Beyond the Alphabet, Revolutionizing EMS Education for Better Results, presented by Jonathan Carolla. I'm going to pass it over to Jonathan now. Thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you, Ria. Just verifying with you too that they can see my screen presentation.
I believe so.
Awesome.
Yep, we're
Cool
good.
deal. Well, good morning, everybody. My name is Jonathan Carolla. I am the education coordinator for Lifeline EMS and a flight paramedic for Lifeline Critical Care. Today, we're going to be talking about how to enhance and make our education process better and go beyond just our typical ABC refresher classes each year. So let's get into a couple things and then I'll start to deep dive this for you guys. So first things first, I have no disclosures or conflicts of interest. There's no financial gains or anything like that for me here. Course objectives. At the end of the session, we're going to be able to recall a couple of the limitations relying on alphabet courses and online training. We're going to be able to review an EMS agency's needs and explore and be able to explain that importance of building a structured education plan and looking at how we can apply components of QA/QI and our LMSs that we use at our agencies to improve our education. So beyond the alphabet, I got the idea from this class a couple years ago because I'm very much a person that if I don't like the way something is, I want to change it. And whether I can change it or not is kind of irrelevant. I'm going to try. I'm a firm believer that if you're going to complain, you should be the person to kind of try to fix it as well, or at least get that process. So I really hate just the standardized ABC classes, your AMLS, PHTLS, ACLS, PALS, what have you. There's, several dozen of them. And, they do what they need to do, right? They give us our Con Ed hours. If you get a really good instructor, you learn some cool tidbits and everything. But even with the changes that come with them every couple of years, ultimately they're the same. And so this class kind of formulated out of that. I'm an education guy by nature. Like my master's degree is a healthcare focused education, specifically to emergency services. So like education's a big thing for me. Also, if you haven't noticed already, I talk with my hands a lot. I can't help it. And with these webinars where I talk to myself essentially, and I can't talk to you guys, I really rely on the chat box and the Q&A portion. So please feel free to keep the chat box very active, have some discussions with, your fellow participants in there, and I'll read them and chime in. And it really just makes this a whole lot of more interactive. And I also don't use a whole lot of stuff on my slides. So it really helps with keeping everybody together and really fostering a quality learning environment. So, let's look at what really makes a good education plan. Um, I can't speak for everybody's EMS agency, but a lot of them that I see and a lot of them that I've worked for in the past have just been, yeah, here's your 48-hour refresher or your 24 for BLS, and here's your yearly or bi-yearly ACLS or PALS or your hazmat, and it just gets stagnant, right? And you lose buy-in. And I don't know how many people in this group are coordinators or supervisors or anything for education and actually handle that portion. But if you are, you know exactly what I'm talking about. And it gets boring. But when you ask somebody, well, make a class, go beyond just, our ACLS every year. Okay, let's do something cardiac, but let's not do ACLS. And then when you ask somebody that, you kind of get like, well, about what then? Or, well, how do I do that? And it's not that normally people don't know how to make a class, they don't know where to start. And I've kind of coined a phrase that when I look at doing any class or someone approaches me about a class, and they want to build it and teach it and present it, whether it's in the agency that I work for or to our community or one of our fire departments, I ask them three simple questions. And these three questions will guide you throughout your entire process of creating a course, and we need to ask it repetitively throughout. And the three questions are one is, why is the class important? So when we look at that, like, what about this class makes it important? What subject, what does it pertain to, and what makes it stand out? Then you need to ask, why is it important to me? And when I say me, I am saying that we put ourselves in the provider standpoint. Is that why should it be important to me as the provider? What am I going to gain from it? What am I going to learn? Yeah, cool that, this new cardiac thing is cool, but why should I care about it? How is it going to do anything for me? And then the third question that plays into this is that how is it going to change or impact my clinical care? And that really is the big one, right? Because we're EMS providers. We're ran all day, we're busy, we're tired, we're all those things. So we don't like change. There's a saying that the only thing that we hate more than the way things are right now is change. And that's true for a lot of EMS providers. Like we never have been like it. We like to be controlled. We like to do things the way we like them, and we don't like to change that. So when it comes to making a class, how is it going to impact me clinically, and what is it going to change to make it even worth going to? So that's kind of where this all started and why it's important and where we got where we are now. So it's all about the buy-in and the trust. Um, I don't know how you guys have handled education classes or getting people to buy in, but like, man, getting people to actually take a class nowadays is tough. And, I hate to say the post-COVID thing, but a lot of it came from everything was, you know, online. It was virtual. It was a static PowerPoint. It was this, it was that. It was easy. There was no tangible class that they had to be responsible for anymore. And we got out of that. And people got lazy. Educators got lazy. Education teams got lazy, and all of it. So people got lazy then. They weren't held accountable. They got all these free passes, and now they don't care. They don't buy what you're selling. They don't trust it. They don't like it. They're going to do the least they can to get by. So how do we change that? And I would like to see some questions or discussion there on like what you guys think of that and what you guys think of how we can change that. What does that look like to us? So if anybody has anything in there, please feel free to chime in. I would be interested to see what we got because we have a good group of people in here that are from all over the US. So I'll give you guys a couple seconds and tell me, how can we improve buy-in and trust? All right. How are we thinking outside the box, Jeff? It don't have to be something real in depth. Just so as Jeff is typing something, hopefully, he's correct. You got to think outside the box. You got to be different. I was talking to a physician, one of our medical directors here the other day, and we were talking about specialties and in EMS and physicians, and he was like, he's like when they want to make a new specialty as a physician, they were like, you have to come to us and be like, what is so different about your specialty that it deserves it? And you have to explain it and give reason. And I think that's really important. And man, look at you guys go here in the chat. Let's see here. Develop a hands-on teach pathophys. I love that. What their needs are. Okay. I love this. Man, this is great. because you guys are really hitting a lot of the stuff that we're going to be going through here on the next few slides and how we can do this. And I love seeing this. Tie cardiology in with pharmacology. I like the letting the people teach, group scenarios, creating kits for students. Ooh, David, that is extremely important there is having buy-in from your system. Um, System usually wants education only when it really matters and after something happens in a reactive perspective versus a proactive. And like all this is true, and you guys are going to see here as we're moving through it, we are really going to hit a lot of these things, you know. And yeah, a lot of those videos are outdated or, they're dry and, you feel like you're being taught by Ben Stein and, you're an old Visine commercial. That's something that I have started to develop a lot in my career as an educator and an education leader is that I've started to build a lot of my own content and it's time consuming and it's tough. But man, has it made a true difference in the amount of education I can provide and how I can provide it to them. And like everything that you guys discussed here, we're really going to start picking into that and going in depth a little bit. We only have an hour, so I can't go too in depth, but hopefully it'll be enough to really give you guys some stuff to take back to your agencies, your educators, or if you're an educator, or an education leader that can make some of those changes. Hopefully you guys can do that too. So it's really good stuff there on building that buy-in and trust. So the first thing that I want to talk about is the learning management system. Whether you use EMS One Academy, you use the one of the train systems, you use Target Solutions, Foam Frat, IAMed, or you're using something like Canva or Blackboard. Like there's so many LMSs out there, right, that you guys can use and pedal with. It doesn't matter what you use, um, because if you use it improperly, it's worthless. You can have the greatest LMS out there, and not use it to its potential and it be garbage. I've seen agencies use Google Drives as their LMS and make presentations and tests and videos and all this stuff just with Google Drive, and it's phenomenal. And it's just bare bones in how they're doing it. And it's because they put the time and the effort. So when we talk about these LMSs and what we can do with them, is this is our first access to our people. It is the fastest, it's the easiest, and it's the best way to connect with everybody in our agency on a topic that needs covered. The problem with that is that it's too easy to do. And more often than not, you will get educators and education leadership that will throw together a static PowerPoint, throw it on the LMS, and then just put a test with it. And do we learn that way? Yeah, sure, cool. I may pick up a couple things from reading the PowerPoint, like, yeah, and then I go take a test, but like, is it worth it? Does it build investment? Does it sell the product of education that we're trying to sell as an agency? Because when we put content out there, whether it's on our LMS, whether it's in person, and even the alphabet classes, right? How we present it and how we give it off is what ultimately determines whether our students are going to take anything from it, you know? And if you're just throwing out static or bland, presentations on our, LMS, then who cares? You're going to get the people that are going to clickbait it and they're just going to click right through it and they're going to hit the things. They're going to go through the slides. And if it's got a time limit that they have to stay in it so long, then they're just going to sit there, wait for the time limit to pass, take the test, and be done with it. And what did you take away from it? Oh, well, I checked the box. But what did you learn? What was tangible? What could you really reach out and grasp from that education? And to me, that's the important part and why the three questions we talked about earlier are so vital to our education process and fostering a learning environment, right? So while it takes time and effort, we need to put that into our learning management systems. And you have a topic that needs to be discussed. The video doesn't have to be an hour. It doesn't have to be this huge, long, in-depth thing. Make a 15 to 20-minute lecture with with the slide deck. Throw some little, nuances in there. Let them hear you as the educator give your heart and soul to that education, and they will begin to buy into it. Because if we're selling a product poorly, then it's a poor product. Very true, Jeff. Quality versus quantity. It's not that our product is, essentially bad, but maybe it's our delivery. It's how we sell it. It's how we get people to engage with it. And, some training just sucks sometimes. It's bland, it's dry, and it's just, there's no way around it. But like, that's the coolest part to me about being an educator, right? Is you can take those crappy subjects and instead of just taking the easy way out, throwing the static PowerPoint on there and letting people run through it, then make it better. And we have that ability to change that and to change a boring, dry topic and make it something cool. And that's really the beauty of it here and the abilities that we have with our LMS. And like most of the LMSs are pretty, savvy when it comes to that. And you have that free reign to do so. And we just don't utilize them like we should. And we miss a big opportunity here with those. And I hate that we do. So let's revamp that. Take that back and be like, here's this static PowerPoint on, you know, let's say we'll just use auto injectors, for example, right? Auto injectors are super simple and they're easy to use and they're easy to teach. And you click through your static PowerPoint, you're done. But why not make that more engaging? Why not create the PowerPoint, create a script to go with it, record it, and even throw in some visuals there. Do some video stuff with it to throw into your lecture as well, so that the students that you're throwing it out to benefit from it. And that's where we can get a lot out of it from. So as we move forward with this, is that we're going to start going into more specific types of education and we're going to break it down some and the parts that I really want you guys to engage and comment on and give some ideas because the stuff you guys type in there can also go out to everybody else too. And it may give someone else an idea at their agency because, like we got people literally coast to coast. There's people from New York, there's people from California on this call. So the stuff you guys say could 100% help them out too. And that's the other part of education is that it's the collaboration. It's not just me sitting here talking. It's me getting you guys to engage with each other. And that's super cool as well. So the other part I want to finish on with the LMS is that when we do these educations, let us make sure that the education we're doing is also relevant to our people. And like I said, going back to the dry content, even though it's dry and that it's not that great, then let's make it that way. So to move forward, let us talk about specific type of trainings and how we can go beyond the alphabet. And the first one I wanted to talk about is ambulance operation training. And people forget sometimes that the ambulance is a very versatile tool in our, you know, paradigm of treatment and transport of patients, and that it's can be used for so many more things than just throwing a patient in, driving them to the hospital. You know, let's talk about initial arrival of a potential MCI with like a 5-car pileup. And now that ambulance isn't an ambulance anymore. It's a triage station. How do you do that? How do you set it up? How do you get that started if you are in a rural area and you say you have a bus crash with 30 patients and you're the first ambulance arriving and your next one out? is 40 minutes. Fire arrives with you, but all they had is like a little command vehicle, and you got a couple extra hands with them. But like, now how can you use that ambulance as your triage station? That is some extremely beneficial training on how to set that up, how people would set up their ambulance, how they would set up their triage areas for when everybody finally did get there to start helping. But how many people have trained on that? How many people have had to do it or even would begin to know how to set it up? Because that's a pretty big challenge, and that really takes that apparatus and takes it beyond just evoc. And we're going to drive through some cones and talk about distracted driving or red lights or traffic hazards, or how would we transport a hazardous materials patient or an infectious disease patient? What does that transport operations look like? How would we prepare as the providers in the back? How would we prepare the ambulance? What would we do for those things? So that's what you got to look at there is there is so many training opportunities and things that, your ambulance, just the ambulance itself can provide you that can do multiple nights of training that, you could do 2 or 3 day trainings on, so let me see what Lindsay said here. Yeah, exactly. Do this stuff at night. I just got done taking T Triple C, and we did task trainers and lecturing during the day, and a lot of our recess operations and rescue operations were done at night. We did a lot of our stuff with headlamps with red light only, and when we had to go extricate people, take them to the aid station, and the aid station we had was only done with had only lighting with glow sticks and or green chem sticks, and we had red lights on our headlamps, and that was it. I mean, you talk about immersing yourself in the environment. And, when we talk about simulation and all this stuff, we talk about high fidelity mannequins and mannequins that can breathe and can cry and can sweat and all this other stuff, which is cool. Don't get me wrong. But the true benefit is the high fidelity environment that we put ourselves in, how we access that affective domain, right? And the thought process and the emotions and everything that we feel during an education session to put us there in real life. So it's really cool with the apparatus to use that type of stuff, And yeah, absolutely. We used actors. We had patient actors for all of our patients, and it was great. It was awesome. But once again, this takes time and effort. And as educators and education leaders, we have to go through and put that time in it. There's the saying that, garbage in, garbage out. And if we want, to do good in our education and we want to provide a grade A quality material, let us put that time and effort in because I promise it'll reward you so much more as you go through. And the great part about it is that once you develop the frameworks and the skeletons for some of these classes, then you'll be able to have the groundwork already laid out for you in the future. So yeah, it'll still take some work to revamp it or revise it or whatever that may be, but you still get to put it out there and you don't have to do all that legwork all over again. So think about that when we talk about our ambulances. One of the trainings that we do in our local area with our fire departments is that we do um, ambulance orientation, where our equipment is, how to access it, how it works, what it does. You know, it's so great to be able to use the piece of equipment, the apparatus is something much more than evoc and taking people to and from the hospital. You know, that's a good point. You like Lindsay and to Jeff and Jennifer, like when you add that stuff in there, it really adds to the immersion factor of our education. My thing is that I want sensory deficits. I want that extra sensory input for my students that I train. I want them to feel overwhelmed. I want them to feel distracted. I want them to feel the stress. Because even though the stress may feel a little different in the training situation, it's still stress that they're going to feel when they're actually doing it, and that they know what to anticipate when they get there. Like, okay, this stress is going to hit me, and I can still think and I can work and I can get through it. You know, because one of the things I was expected to do as, a paramedic in TCCC is know my doses, knows my calcs, be able to give them off, give those, rattle them, pack wounds, do all the things that are involved in tactical field care. And man, it was awesome. It was stressful, but my God, it was so much fun. It was so realistic in the sense of it made you feel like you were there. And smell is the most powerful of our senses, and it is the one that can really put us in an environment. Um, Not to get too morbid, but like the first time you transport a body that's burnt, no one ever forgets that smell. No one ever forgets what it smells like. There's like GI bleeds. No one forgets that smell either. Like those are super powerful. I think that's a really good point. So moving on to the next is equipment-based training. And let's take a piece of equipment, right? Um, I always like to use the hair traction splint as an example, but let's go beyond that. Let's look at finger thoracotomies, or if your agency does them and you're in critical care, or you know needle decompression, and let's see how well people do at it, or crikes, or if you're an agency that does escharotomies, let's look at those really higher risk trainings for paramedics, and for EMTs or AEMTs, let's look at what's high risk for them. You know, and cadavers are great to use, Jeff, but what if you don't have one? You know, that's where the creative part comes in. And, I do a talk on simulation on a budget, and one of the things you can use there is that get a skeleton and get like some type of gel or ballistics gel to act as your outer lining, and then like take that cage and put it over a lung on a Fred the head, and you can really get creative with it. And I can talk forever on creating that. But then for like our EMTs, if you're a state that allows them to do supraglottic airways, have some high risk training with that. Or check and inject, for like epinephrine or Narcan or Zofran. Those are the more high risk ones for EMTs, or even your traumas and extrication from a real crushed up vehicle, or from a small house or a hoarder house. Like that type of training goes so far. And it's not stuff they see all the time, but man, they're thankful for it when they do, because they had that training. So find those training pieces in your agency of equipment that we don't use that often, or scenario or situations that we don't see. I come from rural West Virginia, so there was all kinds of intricate and unique situations that patients found themselves in, that you had to really think outside the box. That's pretty cool. I think that's a really good point there, David. And a rack of ribs is definitely a great way. You know, And you can take that further of you can do the landmark, show the triangle of safety, show them how to find it and where to get to it, and then do like a two-parter there. Like, let's practice how we find the landmarks and do the cut and, insert the forceps and everything. But now let's take this rack of ribs and, you know, let you feel it and what it's gonna feel like, and really create that, realism of, this is a real thing. And, you're physically going to be touching somebody's lung. You're making a hole in their chest and your finger is going inside their thoracic cavity. So I think all that type of stuff, right? That goes way more than, here's a slide presentation on finger thoracotomies. Or if you're going to do a slide presentation, do a few slides, task trainer. Do a few slides, task trainer, finish presentation, simulation, and scenario. That way they have the didactic portion and they get that cognitive part, right? And they get some of the affective domain with it because they're learning it and they feel good about what they're learning. But then when you do the task trainers and then you do the scenario simulation, you're really applying that psychomotor and getting those higher levels of blooms with the psychomotor, cognitive, and affective. And to me, effective is arguably probably one of the most important parts of it because if they don't feel confident and they don't believe that they can do it, it doesn't matter if they know how and physically can. If they don't believe and know that they can, they won't. And that's why training on these pieces of equipment is so important. And even, ones we frequently use, still do a training on that because, a BVM, for example, is one that I like to talk about. And I would say that the BVM is probably the most incorrectly used tool that we have in our arsenal. And it's one of the most important. And we use it every day, all the time. We use BVMs for so many different patient scenarios and or patient, cases and situations. And it's used incorrectly so often. So let's take some piece of our equipment. Let's look at them. Let's see what we're doing with them and really get out there with it and work through those processes. Talk about the E to C clamp. Talk about how, there's some studies out there saying now that, you know, we don't need to use the adult bag valve mask on adult patients, that a pediatric one with an adult mask would work just fine. And there are even a few I've seen roaming around out there. I don't know the brand, but they're even making like small adult BVM bags now because too many people are just squeezing that whole bag and causing all sorts of problems. And if a patient has a pneumo and they don't know that they have a pneumo, like, yeah, barotrauma, you can make the pneumo worse, all sorts of things. And it's makes such a difference. Or take like, where I talked about TCCC, talk about wound packing. You know, I talked to a bunch of EMS providers and, it's kind of astonishing how many haven't wound packed before or how many haven't put on a chest seal or, know why, a vented chest seal may be wanted over a not vented or why we would want a non-vented over a vented. And like those type of trainings, while they may not last more than an hour, go the extra mile. And that's another part of this, right? Is we don't need 3, 4, 5 day, you know, type of classes. These are quick, like just in time type trainings that really stick with people that, you can get your whole agency into, like, get a group here, get a group there, or if you have the ability, just do it while they're working. Drive out to their station, like, hey, let's do some quick training real quick, unless you get a call or, while you're on some downtime. And man, it builds that engagement. It builds that trust and buy-in. And before you know it, you really get all of these people involved. And like one of the struggles I face at my agency is buy-in. Um, because, for a multitude of reasons. I came into it and people just did not buy into the education. And it's a slow fight and a slow push and a slow climb to get it back up. And the big thing with it is that we can't get discouraged because if we get discouraged, then and we just quit, then the people that didn't trust us and said, well, we don't care about education or we don't do that, you know, we're right. They were right. But if we care and we push and we persevere and we win that war of attrition, man, that really helps on that side. So let's look at what Arif said here. Cases together, 7 different skill stations from working ER, MCI, extrication drill. I like that scenario that you just put in there. And I think my favorite part about it more than anything else is that you mix up the group so people have to work with someone they've never worked with before. And I think that is huge. And it's huge because they have to learn and show that one, they have to learn the person they're working with, and two, they have to rely on their skills first, and they can't rely on their partners because they don't know their partner. They don't know their partner's skill level. They don't know anything about them. And it really brings out the best of both people or the best of the group because no one can rely on anybody, dependently because they don't know them. And that's the problem sometimes when you have people that have groups together that know, you have the weaker performers that tend to hide behind the stronger ones because they know them and that they know they'll take up for it and they'll make up that slack. So I really like how you guys do that. And I think there's a lot of benefit to gain from it. So thank you for sharing that. So let's talk about protocol training. And the first thing I think of when people say protocol training is everybody rolling their eyes. Like, right, it's going to be that and I should have put that as the picture. I really should have is the Robert Downing Jr. meme of, him rolling his eyes or the Ben Affleck one of where he's smoking a cigarette. Like I should have used one of those pictures for this, but like protocol training can be probably one of your most beneficial. And I'm not talking about your once again Ben Stein presentation that the state would probably give out on your protocols. But I'm talking about your agency and you creating the protocol education. Let's say that you've had a massive run of pediatric patients or pediatric drownings, because it's the summertime, and I know the areas I've worked in, that's a big one. And actually, the area that I live in, we have had several. So let's do a protocol on that. Let's do some education. And as we do that, let's not only do a protocol, let's make it engaging. Let's make it interesting. Let's make a hands-on day. Let's make it a two-parter, right? Let's make that education on, the protocol for pediatric drowning, but have the protocol there as a reference, but don't just speak the protocol. Speak the intent of the protocol. Speak the emotion of the protocol. We don't need to go line by line, the dry red eyes, Visine is clear type thing. We need to take each point of it and explain it and work through it. And, the pathology, the physiology, and everything that goes into that protocol and how we treat that patient, down from our response to the equipment to, the emotional, fatigue that you may get from it, everything we need to break down. And what's really cool is you could put that part on your LMS if you didn't have time to do it in person. And then you can assign that not as a static PowerPoint. I want to put that out there as a lecture. Give them a quick quiz on it, and then start your just in time training for it, where you don't have to pull everybody together as a group unless everybody wanted to, and you could, and go out to each of your stations, catch different duty rotations, different platoons, and go out there and do that in person. Put 20-minute training and work with them on it. And then if you wanted to and you had the buy-in, do both, right? Do hey, we're going to have 2 days where we're just going to knock this out in an hour with a bunch of groups. And then if you couldn't make it, we'll catch you on your platoon and we'll take care of you. And that works really well. And people enjoy that because they feel they're being engaged by their leadership, right? And educational leadership is leadership. And that goes a long way. So some things to think about with protocol training here, and I hope that that really helps. And someone had said it earlier, and this is probably by far my favorite. And, bonus points to anybody who can guess what that is in that X-ray there. But is provider created training. You want to get buy-in and trust? Use your providers. I will use and abuse my people all day long for education if they're interested. I have a select handful that, well, hey, can we do this for our local fire department? Or, hey, our local law enforcement is interested in learning this. Or, man, I'm really wanting to get into, um, orientation and FTOing. Like, use them. And correct, epiglottitis. It's the thumbprint sign. Because, it looks like your thumb is just sticking out there on that second picture of that X-ray. So good job, Robert. Um, but yeah, so provider created, like, and what I do, and I keep it as an open survey, and I go back and check it, is my there's a QR code at all of our stations, and we use a notification software that's also flashes through um, you as well. That's a QR code that, if they have an education thing they want to do, they scan it and they submit it. Or if they have an education thing they would like to see, they scan it and they submit it. And then I can create it, or I'll reach out to the person and be like, "Hey, would you like to do this?" And then you help them with it. I've done several of our trainings here that way that other people have created. I reviewed it, fine-tuned it here and there, verified some resources, and that's theirs, and let them run with it. And it's worked great, and people have loved it. And as long as you can make sure that it's quality, that it is, relevant, they have good resources, and, they've done their part, it's a wonderful thing. And the crews love it too, because now it's not just me, the education coordinator, teaching it. It's, oh, Jim here, the EMT that's worked with us for, the last 10 years, teaching his peers. And I think that's awesome. And you talk about fostering a learning environment. Man, that's excellent way to do it. And it really, it brings out that engagement and that camaraderie between our crews. EMS is all about camaraderie, right? We all like to engage. We all like to, hang out, talk, laugh, make jokes. But if you're part of a good cultured agency and an organization, when that peer goes up to present or creates an education for their peers, man, people love that. It's so cool. And as an educator, to me, I just love seeing it. Like, education is my passion. I love every bit of it with EMS education. It's been my life. And I really just love seeing people do that. And I've noticed I'm saying "and" a lot, and I apologize with that. So I'll try to fix that for the last part of this presentation. But just so much cool stuff. And I'm loving all of this in here. So the last one that we're going to talk about as we're coming to a close here, probably my personal favorite, is QA/QI based education. And the reason I like this is I am a firm believer in data drives change. We cannot change or fix anything without the data to show for it. And I think that's how we really make education relevant and how you get some of that buy-in. Because if you put on an education, I'll use intubation, for example, since Jeff was talking about, the laryngoscopy videos, is that let because if you ask any paramedic, their intubation success rate, they are the best. They fell down the stairs this morning and intubated 10 people on the way down. But let's see the data on that. Let's go look back at your intubations and how well you've done with it and what intubations you elected to do supraglottic airways because you couldn't get them tubed or you were too nervous or too worried. And let's see those metrics. And a really cool way to do that is you can do it on an agency global scale, right? And not have to call out the individual. So with that, now we have real data on, are we really as good at intubation as we think we are? Are we really good at IVs that we think we are? How many STEMI notifications did we miss out in the field? So this is where QA and education can really become best friends and partners, and they can give you that data. And then you can go out and make that education. More importantly, find a peer, find a provider, because we all have those people here that just, man, they nerd rage out over data and that they just love it and they love looking at it and how to pull meaningful stuff from it. So find those people, elevate those people in your agency to use their expertise in the things that they like. And like you have a person like Jeff, I'll use you for an example. You do this with laryngoscopy. So you worked for my agency and I know you did a lot of intubation training. I'd be like, hey, Jeff, I just reviewed our metrics for first pass success rate on video laryngoscopy, and it's garbage. Like here's the metrics, here's the list of calls over the last, 6 months. Just me and you go through them and see what we can find. And if you want to, you want to make some education on it since you already teach some of this stuff anyway, and see what we can do to make this a little bit better for our providers and how we can assist them. And we can find out then as we deep dive this, is that is it a provider problem, equipment problem, or a system problem? Because with everything, there are multiple, you talk about the Swiss cheese model. When something goes wrong, it's not just, oh, it's this person's fault. There's a whole plethora of things that go into it, and we have to evaluate and look at. And QA, a good QA program really sets the education side up for a lot of success. And I think that doing quality assurance and quality improvement is a great way to provide education for our people so that they can get the most out of it too. But also, it shows them the why, right? It shows them how it directly impacts what we do, the patients they care for, the patients they treat. And it's no longer just, oh, well, man, I missed this IV, or oh, man, I didn't get this tube. Well, as we do our QA and QI, you find out if you're part of a hospital system, it's not that bad. Or if you got good workings with the hospitals you transport to, you do some more digging with QA, QI, and you find out that that missed intubation, you know, because you tried 2 or 3 times, you know, that it's now they have like, say, a laryngeal tear because, you tried to, force that intubation. That's that's huge. And when you put that out there to providers, that goes a long way. So as we come to a close here, because we only got a few minutes left, I want to summarize the stuff we've talked about, and that the alphabet classes are great. They have a purpose and I like them, but they only go so far. And even if you get a really creative instructor that does really good at teaching them, it's still the same concept. It may have a twist here and there, but it's the same stuff, the same process, the same thought methodology, and it just gets repetitive. So let's look at our LMSs. Let's look at what specific things we can grab from our or not our orientation, which that plays a part in it, but our specific pieces of equipment, our apparatus, our QA, QI, all of those things. And remember, the 3 questions that you should always ask, and I do every time, and I will forever die on this hill, is why is what I'm about to teach important? Why is it important to me, the provider that's going to be taking it? And 3, how is it going to impact or change my clinical care? And if we can answer those 3 questions and answer them with certainty, the content of education that we're wanting to do will have a lot of meaning. So thank you guys for taking the time. I left about 5 or 6 minutes here if there are any questions. And I'm going to get caught up on the chat here too.